Hello, this is Victoria, and this is my medication review on lactulose and scopolamine. Lactulose is the generic name for the medication. It has several other brand names. Here is Inulose and Constulose. There's several more. It is an osmotic laxative and an ammonia-reducing agent for people who have liver disease. And are at risk for hepatic encephalopathy. Lactulose is a synthetic, non-absorbable disaccharide. Colonic bacterial fermentation produces this osmotic laxative effect. For constipation, the onset of effect is felt within 24 to 48 hours. With hepatic encephalopathy, it is initiated within 1 to 2 hours, and the effect lasts while the drug is present in the colon. Lactulose is not hydrolyzed by human enzymes, therefore it is poorly absorbed in the GI tract. It reaches the colon largely intact. It is distributed minimally through systematic circulation. It generally passes through the GI tract unabsorbed. Lactulose is metabolized by bacterial fermentation into organic acids and gases, creating an osmotic effect which draws water into the colon and increases stool volume and stimulates peristalsis. In hepatic encephalopathy, colonic acidification converts ammonia into a non-absorbable form of ammonium. It is primarily excreted and changed in the stool. There is usually approximately 3% or less of the active ingredient excreted through urine within 24 hours. Now, lactulose reaches the colon largely intact, where it's fermented by colonic bacteria. In the case of hepatic encephalopathy, it's a pH lowering agent. This actually will convert NH3 to ammonium, where it will be trapped and will not be able to travel systematically to the brain. If people who have hepatic encephalopathy, the ammonia can breach the blood-brain barrier and cause swelling and in the cells and brain dysfunction. So the ammonia is reduced and then it is excreted in the bowels. For constipation, this lactulose increases the osmotic load and water in the stool and results in an increase in peristalsis, which actually helps the bowels to move. Here are some of the pharmacodynamic effects of lactulose. Lactulose causes fermentation in the colon, or it undergoes fermentation in the colon and causes bloating and distension, which produces an osmotic effect. It also contributes to stool softening and increased peristalsis. What the body does to lactulose is it does not digest it, and therefore it is poorly absorbed, and it reaches the colon primarily intact, where it's metabolized by bacteria. So what will that mean to us as dietitians? We can see that, as we've discussed, that lactulose increases water and fermentation in the gut and promotes defecation. So we will need to look for signs of diarrhea. We want to make sure that our patients are meeting their fluid intake to support osmotic action. If they are having discomfort with gas and bloating, then limiting some high FODMAP foods such as dairy, cruciferous vegetables. Um, we want to monitor their electrolytes in case they have diarrhea, especially potassium and sodium. Lactulose has a very small amount of galactose, and lactose, it is generally considered safe for patients with diabetes. However, it may be contraindicated for patients on a low galactose diet. My second medication is scopolamine. That is its generic name. It has several brand names. Its class is anticholinergic, antimuscarinic, anti-anemic, and anti-vertigo. I butchered every one of those words. It can be used orally, also in IV or through intramuscular injections, but it's primarily used in the form of a transdermal patch. We'll talk about that in a minute. It is used for post-operative nausea and vomiting and the prevention of motion sickness. Scopolamine works by blocking acetylcholine at the muscarinic receptors in the central and peripheral nervous system, thereby inhibiting signals from the brain's nausea and vomiting center. Its onset of action is approximately 4 hours after application, and a patch lasts for approximately 3 days. The oral form of scopolamine is limited. It has limited bioavailability due to first pass metabolism. Its peak concentration is approximately half an hour after dosing. The transdermal patch bypasses the first pass metabolism, and its peak plasma concentration is approximately 8 hours after application. It is distributed systematically through the skin, where it will bypass the initial first pass metabolism. Thereafter, it will provide slow and steady dosage for up to 72 hours. Scopolamine undergoes first pass metabolism by CYP3A enzymes. It has a very low bioavailability, and only a small active fraction reaches systemic circulation, which is why in healthcare it's used as preferably as a transdermal patch, and it is excreted primarily in urine. Scopolamine is an anti-muscarinic drug. It competitively blocks acetylcholine at the muscarinic receptor, which shuts down the parasympathetic rest and digest effect. So the parasympathetic nervous system tends to increase things such as digestion and secretions and heart rate, and an anti-muscarinic drug will do the opposite, because you can see on this picture, when you see the muscarinic receptors on this nerve, there's an M1, M2, and M3. We're concerned primarily with this M3, which is regulating smooth muscle of the heart and the GI tract, and also glands such as salivary glands. It's used for blocking the signal in our brain at the vomiting center. And this is just a recap of the effects of scopolamine listed under the pharmacodynamics and pharmacokinetics mechanisms. So I mentioned that the M3 receptors are located all along the parasympathetic nervous system, eyes, the heart, the glands, the respiratory tract, the GI tract, and the bladder. Now, this is where it concerns us as dietitians. The nutrition implications are when you have something that is decreasing salivation, it results in dry mouth, which creates a problem with chewing and swallowing. When it decreases mobility in the GI tract, then that makes a person more likely to become constipated. So what would be an appropriate nutrition intervention for our patients? We would want to promote a texture-modified diet, such as eggs, cooked and mashed fruits and vegetables, soups, puddings, yogurts. We would want to add broths or gravies or sauces to menu items. We'd also want to reduce the choking hazard and aspiration hazard by limiting hard and crunchy, sticky, or dry things such as crackers and dry bread. We want to make sure that people are having small, frequent meals and maintaining their energy and protein intake. Also, we want to promote mouth care. We can promote mouth conditioners such as Biotene and sugar-free hard candies for dry mouth. So for dry mouth and constipation, we want to increase our patients' fluid intake to 2 to 2.5 liters per day. And we also want to make sure that they are maintaining their fiber consumption with prunes, foods like prunes and kiwis and pears, and warm beverages in the morning, non-caffeinated beverages, because alcohol and caffeine also have a drying effect. We want to promote light to moderate physical activity, and perhaps even consider adding a stool softener such as lactulose. These are my references, and thank you for listening to my presentation.